Hello everyone, I'm Ioana Agache from Transylvania University, Brasov, Romania. Very happy to be with you today, although in the virtual format due to overlapping commitments on other continents. So, I was assigned to discuss with you the diagnosis of allergic asthma, and I would like to thank for the invitation to present our new view on this very, let's say, challenging problem. These are my disclosures, none of them are relevant to the presentation that I'm going to give today. So, why is the diagnosis of allergic asthma difficult? Because if you think that this is the situation in the lung, it's a little bit different, for example, from what is happening at the upper airway level. First of all, as it is for the upper airways, you do have an encounter of the allergen, but the allergen comes on the epithelial barrier side together with other environmental factors like pollutants or viruses or irritants. So that's the first thing. It's very difficult to distinguish between what is the allergen doing compared to other triggers that come at the same time with him do at the level of the epithelial barrier. The second part is in the bottom of the slide that you are seeing, is that there is also in the asthma compartment a very strong tissue response. The tissue response with mucus production, with the smooth muscle cell phenotype change, with epithelial mesenchymal transition, these are all, and all the cells that you are seeing at the bottom are secretory cells, which can react additionally to the immune system in the response to the allergen. So it's difficult to dissect, again, the inflammatory response from the tissue response in response to exposure. And you all have patients with severe asthma or moderate to severe asthma where the clear role of the allergen trigger is difficult to separate from the history of the patient due to the situation that you are seeing currently on the screen. Now, I was mentioning that the epithelial is extremely important because, for example, in this study that was recently being published, it has been shown that the epithelial reacts to the aggression of the allergen. And for example, this product derived from its cells, cystatin, will decrease the mite protease activity, so the efficiency of the allergen in driving an immune response. So you also have to put that into your counterpart. That means that we have to have a broader picture of an allergen encounter. So besides being the allergen in combination with other environmental triggers, we have to look very carefully of what an allergen itself is doing at the level of the epithelial barrier. So we start from upper left, where the allergen, as any other danger signal, is encountered by corresponding receptors for danger signals, which are the DAMPs and the PAMPs. And due to their activation and also due to the impact on the epithelial cell, there is a barrier activation and dysfunction. So the tight junctions are loosened, the allergen penetrates inside the tissue, it encounters the dendritic cell. First of all, it recruits the innate immune response, then the adaptive immune response, and then it goes to the classical T2 immune response that we know. But on that, as I was mentioning, in asthma you always have the addition of the tissue response with the release of pro-inflammatory and pro-fibrotic mediators, and this in long-term asthma can be quite strong. And also we have to recognize that besides the backbone, that is the T2 immune response, you always have the T1 and the T3 addition in more severe cases. So for example, you can have local production of IL-6 or the activation of the inflammasome, and this is the T1 immune response, or recruitment of cytotoxic T cells, or a T3 immune response. Okay, Then also in terms of the immunologic response that is happening when you encounter an allergen, you also have to think that besides the production of specific IgE, which we always have in mind in terms of classical allergic reaction, there is also a normal immune response to an allergen by producing specific IgG and IgA. Specific IgA, for example, has a pathogenic role in facilitating the transepithelial traffic of the allergen through the barrier. IgG can activate very early neutrophils in the reaction and can also be a reservoir for high affinity IgE through hypersomatic mutation. Now, in the more severe cases of asthma, there is also an autoimmune response which superimposes to the allergen, for example, with the presence of IgG against products derived from eosinophils or against neutrophil macrophage receptors or the production of antinuclear antibodies. That leads us to the integration, because if we want to see how we diagnose allergic asthma, we have to see where we position it into the current understanding of the asthma endotypes. And as I was mentioning, we usually think of allergic asthma as being a type 1 hypersensitivity reaction with the presence of specific IgE and effector cells like mast cells, eosinophils, and the readout is always the eosinophilic asthma. What drives this is, of course, you cannot have antibody response without cells, so it's a type 2 immune response, which is the majority in immune response in most of the patients that we are seeing. But on top of that, I was mentioning that you have the tissue, which we call the type 5 immune reaction, with epithelial barrier dysfunction, mucus production, phenotype changes in the airway smooth muscles, neurogenic inflammation, and even epigenetic changes that happen in the tissue. If this predominates in some severe cases, then you do not have any more inflammation as a result, and you can say that there is a paucigranulocytic asthma. Or you could have the occurrence of the metabolic syndrome, like obesity, modulating your immune response, or even direct cell activation of some cofactors of the allergen, for example, pollutants that can do direct cell activation mediated through the damaged epithelial bed. Of course, you can have other types, as I was mentioning, of immune response superimposed, like type 4A or type 4C, which drive the different subtypes of severe allergic asthma at the end. Okay, so that leads us to what we can do, having in mind this pathogenic pathogenetic picture, which is quite complicated. It's not so simple that you have only IgE antibodies. What you can do for the diagnosis of allergic asthma. And for that, you also have to think practically. What can you do in the clinic? What can most of us do as allergists, as practicing allergists? So we go resource-wise. So first of all, we have to have a good diagnosis of asthma in general. And here we know that lung function and the demonstration of airway hyperactivity are mandatory. So we cannot just go with symptoms. That's one thing that should be settled from the very beginning, so correct diagnosis of asthma is mandatory. The second thing is a comprehensive clinical history. By comprehensive, meaning that you have to spend a lot of time with the patient investigating the impact of allergen exposure on either asthma clinical expression, so for example symptoms or exacerbation, or asthma evolution, which is the asthma control or responsiveness to treatment. So that's the longitudinal perspective. You also have to include here looking at comorbidities, which can be indicative of an allergic background, for example, food allergy, atopic dermatitis, allergic rhinitis, or a family history, which is also very important. After that, because this is easily being done, and this is quite an important pathogenic arm in the disease, we propose that we keep the testing for specific IgE systemically, either through skin prick test or looking in serum. And then there is an important step. You look if this specific IgE is present, so if the test is positive, either in the skin or in the serum, then there is one important step. You have to check if it is concordant with your history. So you have symptoms starting during the pollen season, or I don't know, during the encounter with the cat, and then you have to have the specific IgE majority to the cat. If it is concordant with history, then you can say that you are in a special endotype, subendotype, which is called IgE-driven allergic asthma, because as I have shown you, allergic asthma can mean a lot more. If it is non-concordant with history, or if it is negative, then you have to decide several things. First of all, which is even the most important, which is point A, if the patient is considered to benefit from targeted approaches such as allergen avoidance, allergen immunotherapy, or other immune modulation, then you go further. Second, if there are resources, if the next steps that I'm going to show you are reimbursed and can be done. It always has to be a shared decision making with the patient. And in these conditions, you refer to a center for allergen challenge. This center has to be qualified for training, you have to have available reagents, and you have to have available time for procedure. Now, if you have a diagnosis of IgE-driven allergic asthma, then you need to check for biomarkers, for example, component resolved diagnosis, blood eosinophils, FeNO. Also assess for asthma severity and control, because then you will decide on different therapeutic options based on, for example, asthma severity. For mild asthma, you will go for allergen immunotherapy. For moderate severe, other targeted interventions. And then you consider, based on the biomarkers and on the asthma phenotype, clinical phenotype, adding allergen immunotherapy or T2 targeted interventions to regular control of treatment. Now we go to the possibility where you can do the allergen challenge. Again, if the patient will benefit out of the allergen targeted interventions, if there is enough resources, and if the center is qualified and you have reagents and you have time to do that. Where in these conditions we propose that you start with the nasal allergen challenge, because it reflects the united airways, and sometimes you have a response from the lung. If it is positive, then you can diagnose allergic asthma. If it is negative, then we recommend the use of a short washout bronchial allergen challenge, which is interrupting inhaled steroids only for 24 hours. And because of that, you can only look at the early reaction, early allergic reaction. If it is positive, again, you have the diagnosis of allergic asthma. If it is negative, then you have to go for optimal washout bronchial allergen challenge, which is very difficult to do in patients with severe asthma, because the withdrawal of the medication will make them unstable. If it is positive, again allergic asthma. If negative, you rule out allergic asthma. I think that this is important, especially for if allergen driven decision is being taken. For example, removal of the cat, or I don't know, something that is very traumatic for the patient. He needs to change the housing, or even the location of where he's living. Now again, if you have the diagnosis of allergic asthma, you go further for further endotyping, checking for T2 biomarkers. Now you can look directly in sputum, because you are doing the challenge, or serum. You can look at basal levels, but even more post-challenge. If the biomarkers are present, then it will aid you consider targeted interventions, and if absent, you can check for other biomarkers, like for example T1, like neutrophils, or T17 neutrophils, or R6, which is T1 immune response, so on and so forth. Now, why the allergen challenge? Because the allergen challenge can unveil all asthma endotypes. If you look at the early response, which is to the left, you can see that you have the classical release of histamine and of products from muscles driven by IgE, but you also have, if you have the possibility to measure, you can look at the activation of the epithelial, which for sure happens. Neutrophils can also be activated in this process, and also monocytes with release of IL-6. Then you have the adaptive immune response with the late response, which can have different flavors, again looking at the main hypersensitivity reactions involved there. So besides the type 4B or type 2, which is the classical allergic response, you can also have IL-17 pathway activated, or the inflammasome with the release of IL-6, or even, as I was mentioning you, the release of DNA traps and proteases, which will lead you to a type 2 cytotoxic immune response. Now, here I would like just to mention, if you look, because this is a new novel methodology that we are proposing for what we are calling the clinical bronchial allergen challenge, or the short washout. So this is only 24 hours interruption of the inhaled steroid. That means that you can only look at the early reaction, the early allergic reaction, especially at the part of the level of the panel where it says measures at home after you discharge a patient, because we put a lot of safety nets there in order not to have late reaction occurring at home, and then the patient needs to be instructed what to do if this happens and how we treat it. I would like to close, because I was mentioning that phenotyping is the endotyping, further endotyping is important, that the importance of the sensitization pattern of the molecular profile of the patient using molecular allergen diagnosis is very important, because as you can see here, for example, DERP21 is very much associated with allergic asthma, especially with severity. Also, other applications of molecular allergology approaches could be, besides the precise diagnosis through CRD and BAT, also optimal selection of responders to either AIT or biologicals, but also in the future maybe novel approaches like adoptive cell therapies. With that, I would like to close and thank for the invitation to present here today, and apologize again for not being able to be in person with you, but very much looking forward to your comments. Please try to contact me via my email that you have. Thank you so much, and I wish you a good conference further.